Migraine is among the third leading cause of disability worldwide. Migraine has a substantial burden of illness. Migraine attacks can significantly impair functional ability at work or school, in social situations, and at home. The severity, frequency, and characteristics of migraine can vary between and within individuals over time, making optimizing treatment challenging. It is important to involve patients in the treatment process to meet individual needs. Shared decision-making involves the clinician and patient in the treatment process to collaboratively make decisions about migraine management. The provider may wish to educate patients about migraine and inform patients that acute and preventive therapies may be needed for successful management, normalize the patient's experience with migraine, and consider use of patient-reported outcomes to better understand the impact of migraine on the patient. The 2021 American Headache Society Consensus Statement and the 2024 Position Statement Update offer providers guidance with use of established and recently approved therapies for the acute and preventive treatment of migraine. The consensus statements recommend that providers incorporate guidance about the benefits of lifestyle modifications and maintaining a migraine diary in treatment plans, set clear expectations and develop realistic treatment goals, and be knowledgeable about treatment options for a balanced discussion with patients on efficacy, safety, and out-of-pocket costs. All patients with a confirmed diagnosis of migraine should be offered acute treatment. The goals of acute treatment include providing rapid symptomatic relief, restoring function, and minimizing adverse events. Based on established evidence, NSAIDs, non-opioid analgesics, acetaminophen, or caffeinated analgesic combinations may be used for mild to moderate attacks. Migraine-specific agents can be used for moderate to severe attacks or mild to moderate attacks with poor response to non-specific medications. Acute treatment with gepants, ditans, or neuromodulatory devices is recommended in patients with a contraindication to or inability to tolerate triptans, or in those who have found at least 2 oral triptans to be ineffective. Triptans and ergotamine derivatives exert effects on the 5-HT1B and 5-HT1D receptors, decreasing release of CGRP from the trigeminal nerve, while also causing vasoconstriction. Alternatively, ditans act on the 5-HT1F receptor to decrease release of CGRP and therefore do not carry the same cardiovascular risk as triptans. CGRP release from the trigeminal nerve leads to vasodilation. Gepants inhibit CGRP activity by blocking CGRP binding to its receptor without causing vasoconstriction. When should preventive treatment be considered? Preventive treatment may benefit people with migraine who have frequent or debilitating attacks that interfere with daily life, who overuse acute treatments, or prefer preventive treatment. The goals of preventive migraine treatment include reducing the frequency and severity of attacks, reducing disability, and improving health-related quality of life. However, only 12% of the 39% of people with migraine who may be eligible use preventive treatment. Along with first-line treatments, CGRP targeting therapies are now considered as a first-line option for migraine prevention without a requirement for prior failure of other classes of migraine preventive treatment. In addition to gepants, which can be used for both acute and preventive treatment, monoclonal antibodies have been developed as preventive treatment to inhibit CGRP binding to its receptor or to bind to CGRP itself. Other oral interventions with evidence of efficacy in migraine prevention include beta blockers, angiotensin receptor blockers, anti-seizure drugs, and antidepressants. Other parenteral interventions with evidence for efficacy in migraine prevention include onabotulinum toxin type A, or botulinum toxin, which is FDA approved specifically for the treatment of chronic migraine. Through interaction with several proteins, botulinum toxin inhibits exocytosis of neurotransmitters and membrane insertion of peripheral receptors involved in pain transmission. Migraine attacks may fluctuate, improve, or remit over time. It is important to monitor therapeutic response to verify that patients have experienced a meaningful change and to identify needs for adjustments to therapy. The recommended time frame for evaluating response varies by treatment type. AHS guidelines suggest efficacy trial periods ranging from 8 weeks up to 6 months, depending on the treatment. Clinicians should consider using patient-reported outcomes to monitor efficacy and treatment response, assessing treatment efficacy based on individual goals, and also collaboratively deciding whether to continue, taper, or discontinue treatment with the patient. The impact of migraine on a patient's life and patient preference is important in treatment decisions. Shared decision-making allows healthcare professionals to empower patients to make informed decisions about their own treatment to improve patient outcomes.